Welcome everyone to the first ever virtual George E. Schweinitz Memorial Lectureship. I am Dr. Michael Salewski, Chair on the section of ophthalmology of the College of Physicians of Philadelphia. As many of you have experienced over the years, this special lecture is given at the historic College of Physicians of Philadelphia, where the famous Mutter Medical Museum resides. Usually, we have our cocktails first in the Ashurst room, and then we move into the Mitchell Hall for the lecture and dinner. So hopefully you kept the tradition alive, even virtually, and pour your favorite beverage of choice and get comfortable on the couch or in your leather chair or at your desk and sit back to enjoy this spectacular lecture. Professor George de Schweinitz was born in 1858 and died in 1938. He attended Penn Medical School, graduating in 1881. He became chair of ophthalmology in the Penn Department of Ophthalmology in 1902, where he held this position until 1929. He was perhaps the most knowledgeable and influential ophthalmologist of his time. Considered one of the greatest lecturers, being sought out to speak all over. He single-handedly wrote the Bible of Ophthalmology entitled Diseases of the Eye, in which 10 editions were written, starting with the first edition in 1892 and finishing with the 10th edition in 1924. I have a copy of this 1924 edition, and it is simply amazing. It covers 865 pages, 434 illustrations, and 7 colored plates. A remarkable comprehensive text, and simply amazing at just how much was known about eye diseases over 100 years ago, including many histopathology photomicrographs, which our guest lecturer, I'm sure, would appreciate. It is with distinct pleasure to introduce this year's 83rd annual lecture, with the first lecture given in 1938 by Dr. Edward Jackson, with subsequent lectures given over the years by giants in the field of ophthalmology, with this being the oldest named lectureship in the United States. Professor Ralph C. Eagle, Jr., whose bio sketch you can read on the original invitation. Dr. Eagle is also homegrown, as was de Schweinitz. Dr. Eagle was born and raised in Chester, Pennsylvania, and then attended college nearby at the University of Delaware, and going on to the University of Pennsylvania Medical School, interning at Temple University Hospital, and then on to an ophthalmology residency at the Shea Eye Institute of the University of Pennsylvania. He was destined for a career in ophthalmic pathology and did a fellowship with Myron Yanoff at Penn, followed by 2 more years at the National Eye Institute, Armed Forces Institute of Pathology under premier ophthalmic pathologists Lawrence Zimmerman and Raymond Font. Dr. Eagle then returned back to Philadelphia, where he led the eye pathology laboratory at Shea from 1978 to 1986, before going on to direct the eye pathology lab at Wills Eye Hospital. He became the Noel and Sarah Simmons Professor of Ophthalmic Pathology at Wills in 1999, where he practices eye pathology to this day. His research interests are vast, focusing on ocular disease using light and electron microscopy. Some highlights of Dr. Eagle's notable discoveries included first authoring an important paper that characterized the ice syndrome, and another landmark paper showing the RPE abnormalities in Stargardt disease were actually caused by the accumulation of abnormal lipofuscin pigment. His American Ophthalmic Society thesis was on the study of iris pigmentation and pigmented lesions of the iris. Dr. Eagle has worked closely with ocular oncologists Jerry and Carol Shields over many years at Wills, co-authoring many papers with them. Dr. Eagle has collected many honors and awards over the years, including the Zimmerman Medal and Lecture of the American Association of Ophthalmic Oncologists and Pathologists, the Macula Society's William Richard Green Lecture, the Pan-American Academy of Ophthalmology's Raymond Font Lecture, as well as too many to list other named lectureships around the world. He has held or currently holds many important leadership positions, including Director of Continuing Medical Education and he chairs the IRB at Wills, and he has held numerous editorial positions on many of the major ophthalmic journals. Dr. Eagle is the consummate teacher, having educated many hundreds of medical students, residents, and fellows over his career that have rotated through the eye pathology lab at Wills and at Shea over many years, and he has given lectures on 5 continents. He has also helped thousands of residents pass their ophthalmic boards after hearing Dr. Eagle's eye pathology lectures and review at the longstanding annual Wills review course. Finally, Dr. Eagle has written a classic comprehensive ophthalmic pathology textbook used by many around the world. Now in its 3rd edition, he has co-authored hundreds of papers and book chapters. In his spare time, Dr. Eagle loves to travel, enjoys art, and is an avid photographer and fossil collector. We are grateful to our sponsors who helped to make this lectureship possible. A special thanks to Alcon, Allergan, Glaukos, Johnson & Johnson Vision, and Lions Vision Gift. And it is now time to turn over the virtual podium to the 83rd George E. de Schweinitz Lecturer, Professor Ralph Eagle, who will enlighten us with the highlights of his illustrious 50 years of ophthalmic pathology in this memorable 2020 year. Ralph, it's all yours.
I am pleased and privileged to give this lecture in honor of Dr. George de Schweinitz. During this talk, I'll review my nearly 50-year career in ophthalmic pathology and discuss some of the interesting things we've seen during the last 5 decades. I have no relevant financial interests or relationships to disclose. Dr. de Schweinitz was born in 1858. He was descended from German nobility on both sides of his family. Both his father and grandfather were bishops of the Moravian Church, and his grandfather, Louis David von Schweinitz, was also a botanist and the father of American mycology. He donated his extensive collection of specimens and drawings to the Academy of Natural Sciences in Philadelphia. Louis David also changed the family name from von Schweinitz to de Schweinitz. Dr. de Schweinitz was the great-great-great-grandson of Reichsgraf or Count Nicholas von Zinzendorf, who played a major role in the foundation of the Moravian Church. Dr. de Schweinitz was born in Philadelphia, where his father was a clergyman. He attended Moravian schools in Bethlehem and Moravian College. He received his medical degree from the University of Pennsylvania and interned at the Children's Hospital of Philadelphia. He became an ophthalmologist when Dr. William Norris asked him to become his assistant. Previously, he had worked as prosector of anatomy for Professor Joseph Leidy at Penn. Dr. de Schweinitz was Woodrow Wilson's ophthalmologist and diagnosed a retinal hemorrhage or vein occlusion in his eye. He served as lieutenant colonel in the Army Medical Corps in World War I. He went to France with the American Expeditionary Force and was superintendent of eye surgery in the most exposed sections of the front. After the war, he was promoted to brigadier general in the Army Reserve. His textbook of ophthalmology was considered the standard authority in the field and went through 10 editions. I use this photo from my grandfather's copy in my retinoblastoma lecture. It shows a child from the Philadelphia General Hospital in the late stages of retinoblastoma called fungus hematoides. Dr. de Schweinitz was professor of ophthalmology at Jefferson Medical College and later succeeded Dr. Norris at Penn. I found no mention of any relationship between Dr. de Schweinitz and the Wills Eye Hospital. Dr. de Schweinitz served as president of the College of Physicians and the American Ophthalmological Society. He was the only ophthalmologist to serve as president of the AMA. He was highly regarded in the United States and abroad and was considered the dean of American ophthalmology. I graduated from the Penn Medical School in 1970. I was interested in ophthalmology because my grandfather, Charles Steitler, was one of the first ophthalmologists in Chester, Pennsylvania. There was no ophthalmology match at the time, and I asked Dr. Harold Shea for a residency. This was during the Vietnam War. Dr. Shea said I could have a residency 2 years after my internship if I got drafted. If I avoided the draft, I could do a 5-year program with 2 years of research. I immediately got into the Army Reserves and started the Penn Ophthalmology Basic Science course in July of 1971. This course was fantastic and it lasted from July to November. Myron Yanoff taught the ophthalmic pathology part of the basic science course using an old carbon arc microscope projector. I enjoyed this part of the course and decided to do my research with Myron. I was Myron's ophthalmic pathology fellow in the old laboratory in the anatomy building at the Philadelphia General Hospital. My fellowship lasted from November to July. During my time in the PGH lab, I found an old camera that fit on the ocular of the dissecting microscope and started taking macro photos of enucleated eyes. At that time, I invented a technique to avoid reflections from the surfaces of the wet tissue by photographing the specimens immersed in alcohol. This is one of my early macro photos. Shows the eye of a pygmy sperm whale that has a massively thick sclera and a blue reflective tapetum lucidum. My first paper was a report of anterior segment necrosis after scleral buckling in a case of hemoglobin SC disease. I also wrote a paper on cholesterolosis of the anterior chamber. This paper was buried in von Grafey's archives because the editor, Fred Blody, had asked Myron to submit a paper to that journal. My fellowship was cut short because the Shea Eye Institute opened in 1972 and Dr. Shea needed more manpower. These photos of mine show the academic procession at the dedication of the Institute, and Dr. Shea with Lord Mountbatten, who attended the dedication. I actually did 3 1/3 years of ophthalmology residency because my residency started in November and finished in July. This is a photo of rounds at the old Philadelphia General Hospital. Dr. Shea's surgery started at 5:30 in the morning. The Shea operating room had 4 tables that were used simultaneously. There was a first, second, and third year resident on each table. Each of them had specific duties to perform. Here's a photo of Dr. Shea performing surgery with loupes prior to the advent of microsurgery. The OR did have an operating microscope, but it was only used for epilation. During my ophthalmology residency, I first met Jerry Shields on a bus at the ARVO meeting on Lido Key in Sarasota, Florida. This was quite fortuitous because there was a 7-month gap between the end of my residency in November and the start of my second eye pathology fellowship in July at the AFIP in Washington. I contacted Jerry, and he helped me get a position as Dr. J. Fetterman's Retinal Research Fellow at the Old Wills Eye Hospital on Spring Garden Street. I had an office in Merlin Rodriguez's eye pathology laboratory. I spent a lot of my time at Jerry Shields' office. This was the early days of the ocular oncology service. My major accomplishment in Dr. Fetterman's lab was this photo that shows the distribution of fluorescein dye in a relatively normal human eye that was enucleated for uveal melanoma. Jerry had his scissors around the patient's optic nerve. I injected a bolus of intravenous fluorescein. We waited 15 seconds and Jerry removed the eye. It was flash frozen with liquid nitrogen and subsequently freeze-dried in a lyophilizer machine that Dr. Fetterman had obtained. I embedded the specimen in paraffin, sectioned it, and took this photo using an ultraviolet microscope. The photo shows the inner and outer portions of the blood retinal barrier. I arrived in Washington for my fellowship at the AFIP 2 days before the bicentennial in 1976. This is a photo of the AFIP building on the campus of Walter Reed Hospital in Northwest Washington. Lorenz Zimmerman was still the director of the AFIP. However, I spent most of my time working with Ray Font, with Ben Fine, and with Ian McLean. I actually spent most of my time working with Ray Font. I'd been warned about working with Ray because he had this propensity to appropriate fellows' projects, but I had no problems because I was interested in things that Ray wasn't interested in, and I frequently got the EM done before Ray got a chance to do it. In addition, Ray and I were both fanatics about gross and photomicrography. Under Zimmerman's direction in the 60s and 70s, the eye branch at the AFIP was the international mecca for training ophthalmic pathologists. The AFIP trained most of the ophthalmic pathologists in the United States, as well as physicians from other countries. This photo shows a few of the AFIP alumni at an eye pathology meeting in 1976. The AFIP was a wonderful place to train. It had a nurturing atmosphere and superb resources. These included scanning and transmission electron microscopy. Essentially, I was able to do EM on anything I wanted to, and I took full advantage of the opportunity. I was particularly interested in the superb images generated by scanning electron microscopy, and I performed scanning EM on a large variety of disorders to make teaching materials that I still use. This is a scanning EM video of the gut-tail excrescences on Descemet's membrane in a case of Fuchs dystrophy. This video follows the path of aqueous humor across the iris to the trabecular meshwork. Here we see the trabecular beams and the canal of Schlemm and trabecular meshwork in cross-section. There's a photo of that normal angle. This shows epithelial downgrowth covering the iris and trabecular meshwork. The characteristic overhanging margin of a Moran's ulcer is seen here. Here's the border of an iris melanoma. Another micrograph of melanoma cells seated on the inner retina next to a tumor that had eroded through the retina. Here we see the meninges of the optic nerve. This photo shows zonular fibers blanketing the pars plana. The pars plicata is seen at top right. I was very lucky on my first day at the microscope. I found some melanoma cells that had artifactitiously exposed nuclei. These had longitudinal folds in the nuclear membrane that correspond with the chromatin stripe found in spindle A melanoma cells. I still use this photo in my melanoma lecture. Early in my fellowship, Dr. Ben Fine invited me to participate on a paper on pseudoexfoliation. This scanning micrograph shows pseudoexfoliation material on the anterior lens capsule. Using transmission EM, we found pseudoexfoliation material in the wall of a short posterior ciliary artery. I wondered whether exfoliation might be a systemic problem, and I tried to find a case in the archives of the AFIP that had pseudoexfoliation and other tissue from a general autopsy, but I was unsuccessful. Years later, a patient of George Space who had pseudoexfoliation died and donated their eyes. I found out that the patient had had a general autopsy at Bryn Mawr Hospital. I took the train to Bryn Mawr and retrieved the tissues. I collaborated with Dr. Barbara Streeton, who was a noted expert on pseudoexfoliation. We found pseudoexfoliation material in the lung and liver, suggesting that pseudoexfoliation was a systemic disorder of elastic tissue. Scanning microscopy also helped me in my research by highlighting features that were inconspicuous or not readily apparent in routine microscopic sections. During my residency at Penn, I was familiar with an interesting group of patients studied by Drs. Shea and Yanoff, who had unilateral glaucoma, ectopic Descemet's membrane on the iris, and pigmented iris lesions. Dr. Shea described these patients as the iris nevus syndrome in his Bedell lecture given at the Bellevue Stratford in 1973. Strictly by chance, I was in the Shea library and I picked up a copy of Documenta Ophthalmologica. It fell open to Kogan and Reese's earlier report of a similar case. Dr. Shea wasn't very happy when I told him about this paper that was the basis for the eponym Kogan-Reese syndrome. Dr. Shea and Yanoff reported their patients in 1975 as the iris nevus Kogan-Reese syndrome. During my fellowship, the fellow who sat next to me at the AFIP found out that he did not like eye pathology and decided to leave his fellowship early. He had processed an eye with the iris nevus syndrome. I was quite interested in his case, and he gave me the remaining wet tissue. I performed electron microscopy on one of the clots shown here. Scanning microscopy disclosed flattening and effacement of the surface of the iris by a sheet of endothelial cells. The endothelial cells surrounded and pinched off parts of the iris stroma, forming characteristic iris nodules. I also found endothelialization of the iris and similar iris nodules, in this case of essential iris atrophy that had full thickness tractional holes. This SEM shows endothelialization and the iris nodule in that case of essential iris atrophy. Bruce Shields and his colleagues in Boston had reported iris nodules in essential iris atrophy earlier that year. I found additional cases with endothelial proliferation and new Descemet's membrane on the iris and angle in a series of cases from the archives of the AFIP. This photomicrograph shows extensive quantities of new Descemet's membrane material in the area of synechial closure in a case of essential iris atrophy. I hypothesized that the different iris abnormalities in the spectrum of unilateral secondary glaucoma could be explained by variations in the pattern of endothelialization. Our paper was entitled Proliferative Endotheliopathy with Iris Abnormalities. The iridocorneal endothelial syndrome was a secondary subtitle. I originally presented this material at a regional ARVO meeting in Oklahoma City. Dr. Ken Kenyon, who was sitting in the audience, pointed out that the acronym ICE stood for the three subcomponents of the syndrome, that is, iris nevus syndrome, Chandler syndrome, and essential iris atrophy. This was totally fortuitous. The Boston group, who had previously described iris nodules and essential iris atrophy, examined a similar small series of cases and came to the same conclusion. The issue of the AJO that contained their paper entitled The Corneal Endothelium and the Spectrum of Essential Iris Atrophy arrived on the day I left for Oklahoma City. They called the process primary proliferative endothelial degeneration. Our terminology was preferred and subsequently accepted. Clinical evidence of endothelial abnormalities, such as dark light reversal disclosed by specular microscopy, was a major factor in the acceptance of this syndrome. Myron Yanoff, who had become chairman at Shea, asked me to return to direct the eye pathology laboratory after my fellowship. Shortly after I returned to Philadelphia, slides and tissue from the clots of another case, previously worked up at another institution, became the basis for another very interesting study. On Thanksgiving Day, a young man ran into a telephone pole in Somers Point, New Jersey, and was fatally injured. He had the variant of Stargardt's disease that had been termed fundus flavimaculatus by Franceschetti. Several months previously, he had been evaluated and imaged at the Philadelphia College of Optometry. His fundus photo shows early atrophic macular degeneration, and his fluorescein angiogram disclosed a characteristic dark fundus appearance with obscuration of the normal pattern, which has been termed the sign of choroidal silence. The patient's mother made sure that his eyes were donated for histopathologic study, which was performed elsewhere. Several months later, she became concerned because she hadn't heard anything and called Dr. Alan Ladies, who was director of research at Penn. He called me and asked me if I was interested in looking at the case. I was extremely interested, and I retrieved the microslides of remaining wet tissue. When I got back to the lab, I looked at the slides and saw that the RPE was extremely abnormal and intensely PAS positive. A prior report in the literature had suggested that the disorder was related to abnormal mucopolysaccharide. This made no sense. I submitted the residual wet tissue for electron microscopy and found that the dark choroid appearance and PAS positivity was due to the accumulation of massive amounts of abnormal lipofuscin pigment in the retinal pigment epithelium, shown here under high magnification. Scanning electron microscopy disclosed striking abnormalities in the retinal pigment epithelium with aggregates of markedly enlarged RPE cells. Stargardt disease, fundus flavimaculatus, was thought to be a classic disorder of the retinal pigment epithelium. However, molecular genetic studies subsequently showed that the ABCA4 gene, responsible for Stargardt's disease, is only expressed in the photoreceptor outer segments, not the RPE. This gene encodes an enzyme which is responsible for the transport of all trans-retinol to the cytoplasm of the rod outer segments. The mutation leads to accumulation of all trans-retinol within the photoreceptor discs. The all trans-retinol combines with phosphatidylethylamine to form a toxic product called A2E. The photoreceptor outer segments containing the toxic A2E are phagocytized by the RPE cells. The toxic A2E poisons the lysosomes in the RPE cells, leading to the massive accumulation of abnormal lipofuscin pigment, which leads to terminal constipation of the RPE cells. Another memorable specimen that we processed was this case of thyroid eye disease. The patient had died from a heart attack at the hospital of the University of Pennsylvania after receiving a single radiation treatment for thyroid optic neuropathy. The photo shows massive enlargement of the extraocular muscles. After dissecting the specimen, I shot 2 rolls of film. I knew I would never get another specimen like this. In 1986, Dr. Hank Perry sent us a specimen from a case of ligneous conjunctivitis. We found that the mass, with its dense, woody consistency, was composed of deposits of eosinophilic acellular material mixed with granulation tissue. The literature on ligneous conjunctivitis stressed that acid mucopolysaccharide was a major component, and some had actually advocated the use of therapeutic hyaluronidase. This made no sense to me. In conjunction with Jack Brooks at the Hospital of the University of Pennsylvania, we did an immunohistochemical stain for fibrinogen and showed that the woody part of the mass was composed of fibrin. We reported this as a letter to the editor of the AJO. Ligneous conjunctivitis subsequently was shown to be caused by mutations in the gene for plasminogen. Our letter to the editor was cited as the first reference in the paper on plasminogen deficiency in the New England Journal. I moved from Shea to the Wills Eye Hospital in May of 1986. Jerry Shields and Bill Tasman played a major role in my move. Bill Tasman was a fantastic chief. He was a strong supporter of me and eye pathology at Wills. Bill and his wife Alice Lee welcomed me and my wife Ava to the Wills family. After Ava passed away, they invited me to share Thanksgiving and Christmas holidays with them at their home in Winmore. Shortly after I arrived at Wills, Dr. Bob Reineke told me about the proposed CLIA 88 laboratory regulations. These were designed largely to prevent dermatologists from practicing the lucrative specialty of dermatopathology. These regulations required that individuals signing out cases had to be board certified in general pathology. This would have decimated ophthalmic pathology by disqualifying 60% of the ophthalmic pathologists who were board certified only in ophthalmology. This photo shows some of the members of the Veerhoff Society who would have been disqualified by the initial CLIA regulations. They include people like Bill Spencer, Dave Kogan, Mort Smith, Vic Curtin, Brooks Crawford, Barbara Streeton, Don Gass, Dan Albert, Ted Draja, and myself. I worked together with Gordon Clintworth, who was president of the American Association of Ophthalmic Pathologists, and his legal team to change the proposed law. A correction to the final rule allowed physicians boarded by the American Board of Ophthalmology who had taken a year of post-residency ophthalmic pathology training to perform tests in ophthalmic pathology. Carol Shields, who had married Jerry in 1985, was my first pathology fellow at Wills. Carol and I examined an eyeball with glaucoma that contained silicone oil. We found that it had invaded the optic nerve, producing a vacuolated appearance that we called pseudo-Schnabel's cavernous optic atrophy. We wrote a paper on this topic. In our paper, we suggested that in glaucomatous eyes, intraocular silicone oil appeared to have a worrisome potential for posterior migration into the central nervous system. 10 years later, a paper was published in the radiology literature that reported migration of silicone oil into the ventricles. This paper cited our original report and our prediction. I had never processed any shaken baby cases before Alex Levin became chief of pediatric ophthalmology at Wills. Alex is a noted expert in the field of abusive head trauma, and he arranged a contract with the Philadelphia Medical Examiner's Office for our laboratory to process eyes. I dissected and photographed the cases, described the pathology, and Alex testified. Here are some of the characteristic features we see in eyes with abusive head trauma. These include numerous retinal hemorrhages that extend to the ora serrata. These include large superficial hemorrhages called cherry hemorrhages that represent focal hemorrhagic detachments of the internal limiting membrane. Optic nerve sheath hemorrhage is another characteristic feature, as are characteristic perifoveal retinal folds. We were able to demonstrate the role of vitreoretinal traction in the pathogenesis of these pathogenic retinal folds. I was invited to give the American Association of Ophthalmic Pathologists and Oncologists Zimmerman Lecture at the 2008 meeting of the American Academy of Ophthalmology. I decided to retrospectively review all of the eyes enucleated for retinoblastoma in our laboratory. Thanks to the busy Wills Oncology Service, we had a wealth of material in our archives. I reviewed 387 eyes that had been enucleated for retinoblastoma. 287 of these retinoblastomas were previously untreated. I looked at the incidence of histologic features that are considered high risk for metastasis. Massive uveal invasion, defined as greater than 3 millimeters in diameter, was present in about 8% of cases, and 12.5% had retrolaminar optic nerve invasion. Either of these features is an indication for adjuvant chemotherapy in most institutions. Flexner-Wintersteiner rosettes represent early retinal differentiation in retinoblastoma. I found that Flexner-Wintersteiner rosettes typically are more common in eyes enucleated from very young patients, and the tumor differentiation becomes poorer with increasing age. The mean age for an eye with numerous Flexner-Wintersteiner rosettes was 8.5 months. In contrast, the mean age for patients who had poorly differentiated tumors was 34.5 months. Florets are photoreceptor differentiation. We found areas of photoreceptor differentiation at approximately 1/5 of the 387 eyes. Photoreceptor differentiation often was found at the base of endophytic retinoblastomas. This supports Helen Damaris and Brenda Galley's contention that retinoma or retinocytoma is a precursor lesion for retinoblastoma. Subsequently, I was asked to be a member of the histopathologic review panel of the Children's Oncology Group ARET 0332 study. This was a prospective study conducted by the COG to evaluate metastatic risk factors in eyes enucleated from children who had unilateral retinoblastoma. A panel of 3 ophthalmic pathologists evaluated the enucleated eyes for high-risk features. Patients with high-risk features received adjuvant chemotherapy. All patients were followed for recurrence. In the study, indications for chemotherapy included massive posterior uveal invasion, defined as greater than 3 millimeters in diameter, optic nerve involvement posterior to the lamina cribrosa, and concomitant choroidal invasion less than 3 millimeters in diameter, combined with any degree of non-retrolaminar optic nerve involvement. The pathology committee was chaired by Dr. Patty Chavez-Barrios at Methodist Hospital in Houston, and the other panel member was Dr. Dan Albert. This was the first prospective study of retinoblastoma conducted by the COG. We prospectively reviewed more than 320 enucleated eyes with unilateral retinoblastomas. We found that pathologists at contributing institutions that often were university-affiliated children's hospitals improperly processed or misinterpreted the histopathology in about 20% of cases. High-risk features were not identified in some cases, or were misinterpreted as being present in others. Improper PO segments made by some laboratories did not include the optic nerve, precluding assessment for optic nerve invasion. Other general pathologists misinterpreted focal RPE detachments by tumor cells as choroidal invasion, or misinterpreted artifactual contamination as choroidal invasion. Overall, 16% of the eyes had retrolaminar optic nerve invasion, and 12.5% had massive posterior uveal invasion. Poorest outcomes occurred in patients who had concomitant peripapillary choroidal invasion greater than 3 millimeters in diameter, combined with 1.5 millimeters or greater of retrolaminar optic nerve invasion. Several patients with this combination died despite receiving adjuvant chemotherapy, and it is thought that such patients may require a more intense therapeutic regimen. During the study, a case from our laboratory led to a change in the COG protocol. The initial COG protocol required submission of only the PO or pupil optic nerve segment of the enucleated eye. This PO segment from our laboratory was submitted to the COG. The child did not receive chemotherapy because high-risk features were not present. Several months later, the patient developed distant metastases. The remaining wet tissue was submitted, and a focus of massive choroidal invasion, defined as greater than 3 millimeters, was found. This was not evident macroscopically. Based on the case from our laboratory, the protocol for dissection and submission of eyes with retinoblastoma now requires submission of both red loaf culottes in addition to the PO segment and a transverse section including the optic nerve margin. Currently, fewer eyes with retinoblastoma are being enucleated due to treatment with eye-sparing intra-arterial chemotherapy. In the early days of this therapy, we examined a small series of eyes that were enucleated after IAC. We found several eyes with thrombosed vessels that contained birefringent foreign material. The foreign material included cellulose fibers, shown here with polarization microscopy, and synthetic fabric fibers. The foreign material was thought to be introduced during the intra-arterial injection of the chemotherapy. The injection procedures were modified, and we have observed no foreign material recently. I became director of the pathology department at Wills in May of 1986. Shortly before I left Shea, I had been nominated for a membership in the American Ophthalmological Society, and I had to choose a topic for my thesis. I decided to investigate iris pigmentation and pigmented lesions using electron microscopy. Two factors contributed to this choice. One was a prior observation that the pigment granules in the melanocytes of the anterior border layer of an iris, in the case of iris nevus syndrome, were larger than the granules in the deeper stroma. Secondly, I remembered a question posed by Ben Fine during my fellowship at the AFIP about what was the difference between light and dark-colored iris freckles. I examined a series of normal irises that varied in their pigment content using scanning and transmission EM. We found that blue and brown irides contained a similar number of melanocytes. The melanocytes in the anterior border layer of a blue iris are transparent because they are relatively devoid of melanosomes. In contrast, the melanocytes in the anterior border layer of a brown iris contain large quantities of melanin pigment, which opacifies these cells, blocking our view of the underlying anatomy. We examined a series of irises that varied in their pigmentation and color. As the color of the iris darkens, the size and number of the pigment granules in the melanocytes increases. The largest stromal granules were found in the case of the nevus ovota. The largest granules are always the granules of neuroepithelial melanin in the iris pigment epithelium. We concluded that a relatively similar number of melanocytes are found in all irides, irrespective of their color. Darker irises have more melanin granules, larger melanin granules, and hence larger melanocytes. My AOS thesis was more than 100 pages long and had 132 figures, which included a number of 3D scanning electron micrographs. I discussed pigmentation and pigmented lesions of the iris in my Ramon Font lecture at the Pan American Society in Cancun. Part of my lecture dealt with iris freckles. Here's a segment of iris with numerous freckles. I submitted this segment for scanning EM. A number of freckles are labeled in this macro photo and the corresponding SEM. Here's a higher magnification, false colorized version. Here's a higher mag view of freckle D2. Under higher magnification, we see the characteristic or raspberry-like appearance or framboisiform cells that are so typical for iris freckles. We also looked at the size of the granules in iris freckles, and we found that the granule size in the freckles is always larger than normal brown stroma. We also looked at Ben Fine's question, how do dark and light freckles differ? Looked at these two examples here. You can see that the pigment granules in the dark freckle are larger. We also had the opportunity to compare both right and left eye of this patient who died from a rare leptomeningeal melanoma, secondary to nevus of Oda. You see the slate gray pigmentation in her darker eye. The left eye with nevus of Oda has a thicker anterior border layer. This is scanning microscopy of the normal medium brown iris in the fellow eye. In contrast, the iris affected by nevus of Oda has the same appearance we saw in the iris freckles, round framboisiform cellular processes. The melanin granules in the iris with nevus of Oda are also larger and more numerous. I gave the International Society for Ophthalmic Pathology's inaugural Gordon Clintworth lecture at the World Ophthalmology Congress meeting in Guadalajara, Mexico in 2016. My topic was clinical pathologic correlation with ocular coherence tomography. In recent years, optical coherence tomography, or OCT, has revolutionized the diagnosis of many retinal diseases. Correlation between OCT and histopathology is often difficult because artifactual retinal detachment almost invariably occurs when eyes are fixed by immersion in formaldehyde. The question is, how do you keep the retina attached? Well, years ago, I developed a technique for processing eyes that prevents retinal detachment. This involves opening fresh, unfixed eyes immediately after enucleation. The eyes are then bisected coronally and fixed by gentle immersion in cold glutaraldehyde. Close cooperation with the World's Oncology Service allowed us to assemble a small series of cases where we were able to directly correlate histopathology with SD-OCT. This photo shows a section through a normal human fovea with the corresponding OCT. Note that the retinal layers in the OCT, which are generated by mathematical algorithms, don't correspond exactly with the histopathology. For example, most of the outer plexiform layer and the outer nuclear layer appear as a dark band in the OCT. This pair of photos shows an eye with early macular changes. RPE abnormalities are seen at higher magnification. SD-OCT shows 4 hyperreflective lines in the outer part of the normal retina. These are thought to represent the external limiting membrane, the ellipsoid part of the photoreceptor inner segments, the outer segment contact cylinder region, and the RPE. This photomicrograph shows the histology of the outer retina. The photoreceptors have inner segments and outer segments. The inner segments also have 2 components: the smaller myoid that abuts the external limiting membrane, and the larger ellipsoid that is packed with mitochondria. Visibility of the ellipsoid layer is thought to be a clinical marker for healthy photoreceptors. One of the cases in our series showed that photoreceptor ellipsoids actually can persist in areas of foveal detachment. So let's go under higher magnification. We can see that there is no distinct ellipsoid in the area of foveal detachment. However, the ellipsoid is readily visible in the area of attached retina at right. Histology shows that the ellipsoid is still present in the area of detachment. Here's another series of photos. This was a patient with severe optic disc edema caused by a small juxtapapillary malignant melanoma. The OCT shows the markedly swollen disc with a suggestion of Peyton's folds on the right. Here's the corresponding histopathology. Note the small tumor within the optic nerve sheath at bottom left. Under higher magnification, we show the axons markedly swollen with blocked axoplasm. In 2017, I reviewed a series of pigmented conjunctival lesions for the Stallard Lecture at the International Congress of Ocular Oncology in Sydney, Australia. We examined a series of conjunctival nevi. We confirmed that the junctional component of nevi diminishes and is lost with increasing age. A subepithelial nevus is a nevus that has lost its junctional component. It is important to remember that a junctional nevus in an adult is the melanoma precursor primary acquired melanosis until proven otherwise. Cystic rests of epithelium are found in many conjunctival nevi, and their presence clinically suggests that a pigmented lesion of the conjunctiva is a nevus. We confirm that the cysts in conjunctival nevi also enlarge as the patient ages. We showed how immunohistochemistry for melanocytic markers using red chromogen helps to facilitate histopathologic assessment and improve diagnostic accuracy. The stains that we use include melon A, SOX10, HMB45, and proliferation marker Ki67. Conjunctival nevi are immunoreactive for melon A, S100 protein, and SOX10 or microphthalmia transcription factor. The subepithelial component, however, generally does not stain with HMB45 and shows minimal cellular cycling with the proliferation marker Ki67. These photos show a conjunctival nevus that has undergone malignant transformation. Both the nevus and the melanoma in the figure at top right stain intensely red with the melanocytic marker melon A, but only the melanoma is immunoreactive for HMB45. In addition, cellular cycling disclosed by nuclear staining with Ki67 is also confined largely to the melanoma. Higher magnification shows the HMB45 stain staining the melanoma but not the nevus. Cellular cycling disclosed by Ki67 is also largely confined to the melanoma. Ki67 also highlights large atypical nuclei in the melanoma. We also discussed the somewhat controversial topic of primary acquired melanosis. PAM, or primary acquired melanosis with severe atypia, is a major precursor lesion for conjunctival melanoma. PAM with severe atypia, which is also called melanoma in situ, shows extensive replacement of the conjunctival epithelium by atypical melanocytes. There's atypical intraepithelial melanocytic hyperplasia. Patients with PAM with severe atypia or melanoma in situ are at high risk for progression to invasive melanoma. A variety of somewhat confusing terms have been suggested for this important melanoma precursor lesion. My colleague, Dr. Tatiana Millman, currently is spearheading an international collaborative study of primary acquired melanosis using virtual digitized microslides. Hopefully this will help to improve and standardize the pathologic assessment and nomenclature of these difficult lesions. With colleagues at several other institutions, we reported a series of eyes with unsuspected uveal melanomas that had been treated with evisceration. I've seen a number of such cases. This was an elderly woman seen at Wills who had a largely necrotic melanoma and was thought to have endophthalmitis and was eviscerated. This is an evisceration specimen from elsewhere. The patient was a 26-year-old Hispanic woman with a blind, painful eye. The possibility of a tumor was considered unlikely and she was not imaged. The evisceration specimen contained a mushroom-shaped mixed-cell melanoma. Subsequently, my fellow Swati Kaliki and I reported a series of eyes with unsuspected tumors that had been treated with tube shunts for glaucoma. Several of these cases were children with meduloepitheliomas who developed neovascular glaucoma. In this photo, we see the tube shunt next to the large anterior segment tumor. In one of these cases, extraocular tumor was found in the tube shunt reservoir. A significant number of eyes with retinoblastomas and medullopitheliomas develop neovascular glaucoma. An intraocular tumor should be strongly considered in any child with neovascular glaucoma. There have been remarkable advances in ophthalmology during my career. Microsurgery, extracapsular cataract surgery, intraocular lens implantation, phacoemulsification, laser photocoagulation, vitreoretinal surgery, diagnostic ultrasound, refractive surgery, OCT, anti-VEGF therapy for age-related macular degeneration and diabetes, lamellar corneal surgery, eye-sparing therapy for intraocular tumors, and most recently, gene therapy for inherited diseases. I recently had cataract surgery. My outpatient experience took about an hour and 15 minutes, and I was 20/20 without glasses on the day after surgery. A far cry from the 5-day hospitalizations and thick aphakic spectacles that were standard during my residency. There have also been changes in eye pathology. Electron microscopy has been largely supplanted by immunohistochemistry, which has markedly increased diagnostic accuracy. In recent years, molecular biology and genetics have disclosed new biomarkers, including mutations, translocations, and fusion proteins that serve as important diagnostic markers and prognostic indicators. The STAT6 marker has shown that lesions previously diagnosed as fibrous histiocytomas or hemangiopericytomas actually are solitary fibrous tumors. Specific translocations also distinguish embryonal rhabdomyosarcoma from alveolar rhabdomyosarcoma, which has a poorer prognosis. Special stains can also determine whether a tumor is a good candidate for targeted therapy with agents like checkpoint inhibitors. In recent years, our iPath lab has increasingly become more of a general surg path lab that accesses ocular adnexal structures rather than eyes. There has been a change in specimen mix. Fewer eyes are being accessioned. At the Eastern Ophthalmic Pathology Society meeting in 1986, 61% of the cases that were presented were eyes. In contrast, the number of eyes presented at the Bierhaus Society meeting in 2013 had decreased to 39%. The total number of cases that the lab receives has gone up slightly, but there's been a marked decrease in the number of globes accessioned. There has been a striking decrease in the number of posterior uveal melanomas received, and there's also been a slight decrease in the number of retinoblastomas. Fortunately for patients, the decrease in the number of eyes accessioned reflects more effective therapy. When I started in eye pathology, one of the most common eyes we got in the lab was an eye with neovascular glaucoma that developed in a patient after central retinal vein occlusion, so-called 60-day glaucoma. There's been a marked decrease in the number of such eyes. This reflects therapies like PRP and tube shunts and anti-VEGF drugs. There has been another recent trend. Many ophthalmic pathologists are now trained and boarded solely in pathology. This is generally the case in Canada and the UK. Most general pathologists are not interested in eye pathology, most lack training in eye pathology, and they are generally afraid to deal with eyeball cases because they lack the knowledge and experience to adequately assess such cases. Only ophthalmologists are interested in ophthalmic pathology, and they generally are less interested in the cases that interest the general pathologists, for example, soft tissue tumors of the orbit. Regarding training for ophthalmic pathologists, I do recommend training in general pathology due to the increasing complexity of pathologic practice. I also think that training in ophthalmology is very important, especially when it comes to assessing eyes in strictly ophthalmic processes. I believe that board certification in both ophthalmology and general pathology is optimal training for ophthalmic pathologists. I've done a lot of teaching during my career. I started lecturing at the AFIP ophthalmic pathology course in 1978 when I was a fellow. I became a member of the Lancaster course faculty in 1980 and became director of the eye pathology section in 1992. I lecture in the course and run the laboratory. I've given numerous intensive reviews of ophthalmic pathology at the Wills Review course and other institutions in the United States, including Columbia University, the Cleveland Clinic, and the University of Puerto Rico. I've also lectured abroad in Saudi Arabia, Kuwait, in India. I wrote and illustrated a single-author textbook of eye pathology designed for students and residents. This has become quite popular and now is in its third edition. These teaching venues and other eye pathology conferences have allowed me to see some interesting parts of the world, including China, Japan, Australia, Iceland, Mexico, and several countries in South America. Ophthalmology residents from Wills and 4 other residency programs currently are trained in ophthalmic pathology in our laboratory. We also have a very popular rotation taken by medical students who are interested in ophthalmology careers and letters of recommendation. Current members of the Wills staff, including several service chiefs, have taken my rotation in the past. I've written letters of recommendation for a number of students who subsequently became chief resident at Wills. I've had relatively few fellows since I've only accepted post-residency fellows because they're the only ones eligible to sign out cases according to the CLIA laboratory regulations. A large percentage of my ex-fellows do ocular pathology or ocular oncology, and 3 of them are members of the American Ophthalmological Society. Training in ophthalmic pathology is a valuable foundation for residency training in ophthalmology. I still work full-time in the lab at Wills, and I particularly enjoy grossing enucleated eyes with the residents and students. Opening eyes is like opening Christmas presents. You never know what interesting things you'll find in a blind, painful eye. Thank you for your attention.
We have a lot of comments congratulating you on the chat line, and lots of your friends all over the world, I'm sure that have linked into this. Really appreciated this just amazing talk, and we'll try to pose a few questions to you, and then we can finish up. So let me try this first question from Scotty Goldstein. It seems electron microscopy is not as prominent today in the molecular era of medicine. What role does electron microscopy play in 2020?
That's quite true. I haven't done EM in about 10 years. I think EM is still used in research and some types of research. I think clinically it's still used to evaluate some renal biopsies, things like that. But again, it's immunohistochemistry gives better information, and it does it faster and cheaper. So that's one of the reasons it went away. I'm sorry that scanning EM went away. I used to love doing that, and it's interesting. They have new scanning microscopes. One at the College of the Academy of Natural Sciences is about the size of a computer. They've gotten better too, but I don't do it anymore. Does that help?
That's great. Here's a question from Richard Spade. GNAC mutations are found in choroidal melanomas, but is also found in circumscribed choroidal hemangiomas. Do you have any thoughts on this matter?
Yeah, they're very basic mutations. They're actually also found in non-syndromic birthmarks in Sturge-Weber syndrome as well. They're found in nevi. They're found a lot of things.
Here's a question from Dr. William Lloyd. Ralph, you have reported on many of the amazing transformational changes that have occurred in laboratory medicine as it relates to diagnostic ophthalmic pathology. In your own words, how has the education of ophthalmology residents evolved during the same period, and what changes would you recommend going forward?
Uh, Bill, that's a difficult question. I think that there's been a lot less education of ophthalmology residents recently, less emphasis on it, less emphasis in examinations. And I think uh, some of that probably is necessary. We're very lucky here at Wills because we still have a full standing eye pathology lab. Again, we do teach residents from 4 programs here. The question, do residents really have to know histopathology? I think, however, I think that eye pathology training and information is a great foundation for ophthalmic training.
Agreed. Here's another question. Any insightful thoughts or experience on Corona-19 viruses and eye pathology?
Not that I know. We actually had a case of an eye from a patient supposedly who had COVID, but there wasn't anything specific in it. I personally have no experience.
Well, this lecture was attended by more participants than anyone than maybe in the history of the lecture. The nature of the virtual process has allowed that to happen, and we've had people from all over the country. There were 337 people that have registered for this talk, and many of those have been with us tonight. So it's an incredible turnout, just a testament to Ralph, how great you are, and how many students, residents, fellows, and attendings that you have taught in your career. And we're also very thankful to have had that occasion to learn from you and continue to learn from you. You're still going strong, it seems, and we look forward to more discoveries in the rest of your career. Now, because we're not here live, we would normally be presenting you with the traditional Philadelphia Bowl that all of the speakers have been getting for the last few decades. This will be presented to you next year, but you will receive it in the mail. So enjoy it, display it on your mantle, and cherish it, because you are one of the very special lecturers on this very historic lectureship. And as I said, the oldest lectureship that I'm aware of in the United States. And Edward Jackson gave the first lecture in 1938, right after the death of George de Schweinitz. And it wasn't until almost 10 years later that the first Edward Jackson memorial lecture was given at the American Academy of Ophthalmology. So this lecture certainly predates that. And again, thanks, and everyone, thank you for attending, and very much appreciate it, Ralph, and we hope to see you many years to come.
Well, thank you very much for inviting me. It's a great honor to give this lecture.
It was fantastic, and Professor de Schweinitz, I'm sure, would have enjoyed it immensely wherever he is to have listened to this. Thank you so much.
Thank you. Good night.